Hello, everyone, and welcome to Health Reform Beyond the Basics. Thank you for joining us for our fall series for coverage year 2024. Today's webinar is Plan Design. My name is Ayesat Odiale, and I'm the Health Projects Assistant at the Center on Budget and Policy Priorities. I'll be moderating today's webinar. Beyond the Basics is a project of the Center on Budget and Policy Priorities. It's designed to provide training and resources to facilitate enrollment in the ACA health insurance marketplaces and Medicaid. The Center on Budget and Policy Priorities is a nonprofit policy organization. We are not a part of the U.S. Department of Health and Human Services. Beyond the Basics is aimed at healthcare assisters, advocates, state and local officials, and others who help people get and keep their health coverage. This webinar is not intended for press purposes, and while we hope you will learn a lot, we are not able to offer continuing education credit for our webinars at this time. Next slide. Automated captions have been enabled for this webinar. To view them, you can click on the More option with 3 dots at the bottom of your screen, or you may see 2 C's as an icon at the bottom of your screen, and you can turn on the closed captioning. All participants are muted and in listen-only mode. However, if you'd like to ask a question, you can click on the Q&A icon at the bottom of your webinar screen and type your question into the box. We will be monitoring questions and will pause for Q&A during the presentation. We may not be able to answer every question asked, but we will record all of your questions and will use them as a guide for future resources and presentations. And of course, you can email your questions during and after the webinar to beyondthebasics@cbpp.org. A quick reminder that you will not be able to click on your screen to go to any of the links shared in the deck, but I will put a link in the link for the slides in the chat, where you can find all active links to everything shared today. And of course, after today's webinar, we'll email a recording of this entire presentation along with the links to the slides and other resources. And we'll also post everything to the Beyond the Basics website. Next slide. So here you can see the schedule of webinars in our fall series. We're about halfway through our series, and following today, we will have more to come with plan selection strategies, the annual renewal process, the second part of our webinar on eligibility and outreach and application issues for people who are immigrants, and tying it all together, the webinar where we help you understand how all the concepts in the series fit together. We will still cover the same core concepts we always do, but we've added new examples throughout the series and, of course, integrated updates as policies have changed. We're also pleased to once again host a webinar in Spanish that focuses on enrollment issues most relevant for people who are immigrants and people who live in mixed immigration status households. We're also excited to be celebrating 10 years of marketplace coverage as a part of our series this year. And as a part of our celebration, at each webinar, we'll be spotlighting veteran assisters from around the country. Next slide, please. Today's webinar will cover elements of qualified health plans, different plan types, how cost-sharing charges work, meeting of metal levels and actuarial value, and cost-sharing reductions. Today's presenter is Claire Heyison, Senior Policy Analyst on the CBPP Health Team. Claire specializes in health insurance and marketplace policy. Now I'll turn it over to Jenny for our anniversary segment and to get us started.
Great. Thanks so much, Ayesat. And thanks everybody for joining us this afternoon. We're really glad to have you. So we're actually featuring 2 assisters as part of our anniversary celebration today. First, we have Josh Newland. Josh is Outreach and Enrollment Coordinator with the Ohio Association of Food Banks Navigator Consortium. He's been doing enrollment work for 10 years and serves a large portion of mostly rural Southern Ohio. He was nominated by Zach Reed from the Ohio Association of Food Banks, who talked about Josh's willingness as a navigator. Zach says, "When Josh doesn't know the answer, he seeks it out. When navigator funding was reduced, Josh embraced his role as a certified application counselor. When he's confronted with negative attitudes toward the Affordable Care Act, he calmly provides accurate and unbiased information. There's no partner that Josh is unwilling to engage, process he is unwilling to try, or difficult conversation he is unwilling to have. Josh shared a few words of wisdom for other assisters as well. He says, always be empathetic to everyone's situation and be open and honest. You need to be knowledgeable, but you also need to acknowledge when you need to do more research. You will run into situations that aren't cookie cutter. Having readily available resources is as important as having everything memorized. Never stop collecting resources. Next slide. We're also featuring Sandra Algarin today. Sandra is a certified application counselor and outreach and marketing lead with Community Health Centers, a network of federally qualified community health centers in Central Florida. She's been in this role for 5 years, but she's been involved in marketplace outreach and enrollment since the very beginning. In the early years of the marketplace, she was a volunteer with Enroll America, helping consumers understand what the ACA was all about and how to apply. Then for a time, Sandy was unemployed, but she continued to volunteer to get folks enrolled. And eventually she became a navigator with an organization for a short amount of time and ultimately landed where she is now, working in outreach and community relations and as a CAC with community health centers. Sandra helps clients in English and in Spanish. She says to be an effective assister, you have to be a good listener, have compassion, and have the commitment that, yes, there is always a way to help someone in need of information and services. And her advice is never assume and be patient. Thank you so much to both Josh and Sandra for the invaluable work you do for your communities. We appreciate you and we hope you enjoy your anniversary tumblers. With that, I will turn it over to Claire to get us started. Claire, we can't hear you.
I'm so sorry about that. Thank you, Jenny, and thank you everyone for joining us today. My name is Claire Heyison. I'm a Senior Policy Analyst at the Center on Budget and Policy Priorities, and today we'll be talking about plan design. So we'll get started with some basic information about qualified health plans, or QHPs, which are the plans sold on the marketplace. So qualified health plans, or QHPs, are insurance plans that must meet certain standards and include consumer protections outlined in the Affordable Care Act, or ACA. These protections include having coverage for pre-existing conditions, covering the 10 essential health benefits, or EHBs, having cost-sharing limits that follow federal regulations, and not having any annual or lifetime limits on benefits. QHPs must also be certified by the Federal Health Insurance Marketplace or a state-based marketplace. And these are the 10 EHBs that all QHPs must cover. That is an ACA requirement. These include preventive care, hospital care, prescription medications, maternity care, pediatric care, and more. Another important element of all health plans, including QHPs, is the plan's network. A plan's network is made up of all of the physicians, hospitals, and pharmacies that have contracted with the plan to provide services to plan enrollees. Providers that the insurance company does not contract with are considered out of network. And while some plans will cover services that the plan enrollee receives from these providers, they will usually have to pay more out of pocket than they would if they went to an in-network provider. And some plans won't cover any services received from an out-of-network provider at all, except in cases of a medical emergency. It's very important to know that every plan has its own network, and even plans offered by the same insurer can have different networks. There are 4 basic types of plan networks, and they're listed here with the least expensive but most restrictive network type on the left, and the most expensive but least restrictive network type on the right. So first, we'll talk about HMOs, which stands for Health Maintenance Organizations. This type of plan requires enrollees to have a primary care provider or PCP, and the enrollee must get a referral from their PCP if they want to get care from other in-network providers. Their networks tend to be relatively small, and any services received from an out-of-network provider are not covered at all by the plan. The next type of plan we'll discuss is an EPO, or exclusive provider organization. This plan does not require enrollees to have a PCP, and they don't similarly require referrals to see other types of providers. But similarly, similar to an HMO, these plans do not cover any care that's received by an out-of-network provider. Next is POS, or point of service plans. So these plans, like HMOs, require the enrollee to have a primary care provider, require the primary care provider to provide referrals, and tend to have relatively smaller networks. However, they do allow enrollees to see providers that are out of network and cover some of the cost of that care. Finally, there are PPOs, or preferred provider organizations. These have relatively larger networks, do not require a primary care provider for referrals, and do cover some of the cost of care for services received out of network. Another basic element of QHPs is the formulary. So a formulary is a list of medications that an insurance plan will pay for. The formulary splits up covered medications into categories, or tiers, to indicate the level of coverage the plan provides and the portion of the cost the enrollee will have to pay for various medications. In general, the higher the tier of medication, the more the enrollee will likely have to pay. So with the example on the right, you can see that the tier 1 medications are the least expensive and tier 4 is the most expensive. Generic medications are usually on the lowest tier, which means the enrollee will pay the least for these medications. And medications that are not listed in the formulary at all are generally not covered by the plan, although exceptions may sometimes apply. So now that we've covered networks and formularies, let's talk about cost. There are two main categories to be aware of when it comes to plan cost. The first is the premium, which is the monthly cost that a person pays for their health insurance plan. And premiums must be paid every month or the person's plan may be terminated. The next type of cost is cost-sharing charges. And these are the costs that a person pays whenever they use their healthcare services that are covered by their insurance plan. And you can find all of this information on the plan cards listed on healthcare.gov. Some of you may have noticed that these plan cards have been redesigned since the last open enrollment. So at the top, you still have some basic plan information like the name, the insurance company, the metal type, and the network type. In the middle, there is now some more detailed information about cost sharing. And at the bottom, you can now enter in a person's preferred healthcare provider or medications that they know that they'll need and see at a glance whether those things are covered by the plan. Another new feature for 2023 is the ability to estimate a person's total yearly cost. I think the best way to think about this feature is not as a crystal ball, but as a simpler way to compare plan costs. So instead of looking separately at a plan's premium and deductible and out-of-pocket maximum, the total yearly cost estimate gives you one number that combines everything based on how much healthcare a person expects they'll need over the next year. Keep in mind that this number assumes that the enrollee will only use in-network care and doesn't account for unexpected healthcare issues that may arise. Next, let's take a deeper dive into cost-sharing charges. We'll spend a lot of today's presentation focused on cost sharing, given how complex this topic is and how consequential it can be for enrollees. We'll start by talking about three types of cost sharing. So there's the deductible, which is the amount that an enrollee must pay out of their own pocket for healthcare services before their insurance plan kicks in and starts paying. And the deductible resets at the beginning of every year. Next, there are copayments. So with a copayment, the enrollee pays a set dollar amount for healthcare services and prescriptions. So an example of a copayment would be something like $25 for a primary care office visit. And then there's coinsurance. And with coinsurance, the enrollee would pay a percentage of the total cost for healthcare services and prescriptions. So coinsurance might look like 20% of the costs of a hospital visit. And as you might be able to tell, it's a little bit more difficult for people to predict what their coinsurance responsibility might be compared to a copay, because people often don't know in advance what their total healthcare bill is going to look like. Some other things to know about cost sharing. Some plans may cover certain services pre-deductible. So let's say a person has a plan with a $3,000 deductible and a $25 copay for primary care sick visits. If a plan covers primary care sick visits pre-deductible, then the person will only pay $25 for that service starting on day one. But if the plan doesn't cover primary care sick visits pre-deductible, the enrollee would need to spend $3,000 out of their own pocket before their plan pays anything for that primary care visit. So very important to look for pre-deductible coverage, sometimes called first dollar coverage, or noted with a term like deductible does not apply for services that enrollees might be using often. Additionally, some plans may have a separate deductible for prescription drugs. And finally, because of the ACA, preventive care services are required to be provided without any cost sharing. So that means no deductible, copayment, or coinsurance. And some examples of preventive care services include well woman visits, screenings for cancer, diabetes, hypertension, or other chronic conditions, immunizations, and FDA-approved contraceptives. Now, there is a lawsuit making its way through the courts right now that challenges the ACA's ability to require that preventive care be covered at no cost to the enrollee. But as of now, that part of the law is still in effect, and all qualified health plans must cover these services without cost sharing. So next, there's the maximum out-of-pocket limit. And this puts a cap on the amount that an enrollee can pay in cost-sharing charges in a year, protecting people from very high out-of-pocket costs. Like the deductible, it resets at the beginning of the year, and it applies to in-network services, generally not for out-of-network care. The out-of-pocket limit is not the amount that an enrollee must spend each year. It's the maximum an enrollee could spend in a year. Copays, coinsurance, and the amount that an enrollee pays toward their deductible are all counted toward their out-of-pocket limit. Premium payments are not counted. Remember, that's separate from cost sharing. And after an enrollee reaches their out-of-pocket limit, the insurance plan pays for 100% of in-network healthcare costs with no copays or coinsurance. Some plans will have the maximum OOP limits allowed, whereas other plans will have lower OOP limits. And when I say maximum OOP limits allowed, federal law requires QHPs to have a maximum OOP limit of no greater than a particular number. So you can see that for 2024, for individual coverage, the out-of-pocket maximum, the highest out-of-pocket limit that a QHP can have is $9,450. And for a family plan, the maximum OOP limit is $18,900. So let's talk about how this works in practice. This is Anita. For this example, we're going to assume that all of the care Anita receives is in-network, and we're going to assume that the healthcare incident we're going to talk about occurs at the start of the year before she has received any other healthcare. So Anita has health insurance. Her annual deductible is $6,100, and her annual out-of-pocket limit is $7,500. In 2023, Anita has some kind of accident or health issue that leaves her with $27,000 in medical expenses. So Anita is responsible fully for any amount before she hits her annual deductible. So up to $6,100, Anita is responsible for paying for the full amount of her care, and the insurer does not pay anything. But once Anita hits her annual deductible, her plan kicks in, and she is now responsible for co-payments or co-insurance, and her plan kicks in to pay the rest of the cost of these services. So you can see here that the cost is split 50-50. And then once Anita hits her plan's annual out-of-pocket limit of $7,500, the insurer pays for everything, and Anita does not pay anything else. This is Anita's health plan. As you can see, it has a $6,100 deductible and a $7,500 out-of-pocket limit. To find detailed information about how much Anita is expected to pay for specific services or medications, you'd want to take a look at the plan details circled in red. We'll get into that a bit more later, but for now, I'm just going to provide an overview of that information. So up at the top here is an overview of Anita's cost-sharing responsibilities for the services she needs after this $27,000 incident. And you can see that for most health services, after Anita hits her deductible, she is responsible for 50% of the costs of her care, and the plan is responsible for the other 50%. And for medications, she has a copay of $30 per medication, which starts on the first day of her plan. So no need to hit the deductible first. So the first charge that Anita receives on her bill is $1,000 for her ambulance costs. She hasn't met her deductible yet, so she is responsible for this full $1,000. The next item that Anita is charged for is a hospital facility fee of $7,000. So she pays the remaining $5,100 to hit her deductible of $6,100. And then after that point, she has 50% coinsurance. So she pays for 50% of the cost, the remaining cost, $950, and the plan picks up the other $950. Next, she is charged for hospital physician services. She's charged $15,000 for that. But she only ends up paying $450 because after that, she's hit her out-of-pocket limit, and the plan picks up the rest. And so similarly, it ends up that she needs imaging and some medications as well. But because she has hit her out-of-pocket limit, the plan picks up the costs for those services as well. So the total amount that Anita is responsible for paying for this $27,000 medical expense is $7,500. So I mentioned earlier that we're assuming that Anita's care is provided entirely by in-network doctors. And this is important because she'd likely end up paying much more if she went to an out-of-network hospital. So in this example, we see that an enrollee has a plan that has a $5,000 annual deductible for in-network care, a $9,100 out-of-pocket limit for in-network care, and a primary care visit copay of $25. For out-of-network care, the annual deductible is double, so $10,000. There is no annual limit of how much she can pay out of pocket. And for primary care visits, she'll be charged 50% coinsurance of the plan's allowable charges. And the allowable charges or allowable cost is the maximum amount that a health insurer decides that they will pay for an out-of-network visit. And oftentimes, doctors' offices and hospitals will charge more than the insurer's allowable amount, leaving the patient on the hook for any amounts above what their insurer will pay. So you can see here for an in-network physician, the doctor might send a bill for $200, but if they are in-network, they've contracted with the plan and agreed to accept a rate of $100. So the enrollee would be responsible for their $25 copay, which would count toward their out-of-pocket limit, and the plan would pay the rest. But for an out-of-network physician, the doctor would bill $200, the plan would say, okay, we're only going to pay 50% coinsurance on our allowed amount. So 50%, or sorry, $50 for the plan and $50 for the patient. But the doctor would still want to collect that remaining $100 and would send that bill to the patient. And this is called balance billing. And the patient's $150 expense would not count toward their out-of-pocket limit. Next, we're going to talk about actuarial value. This term essentially refers to the generosity of a plan, or how much of the cost of healthcare the plan will pay for versus how much the enrollee will pay for. So again, it's a way to compare the generosity of plans. And as you may know, marketplace plans are organized into 4 metal levels: bronze, silver, gold, and platinum. And each metal level is associated with a different actuarial value. In general, the higher the AV, the less cost sharing the enrollee must pay. And AV does not represent what the plan pays for a particular individual enrolled in the plan. That's very important. And enrollees' actual out-of-pocket costs depend on the medical services they use. AV represents the amount that the plan would be expected to cover on average for an average population, not for a particular person. And AV, likewise, shouldn't be confused with coinsurance. So if a plan has a 70% AV, that does not mean that the enrollee is responsible for 30% of all of their healthcare costs. Also important to note that actuarial value is not meant to represent the quality of a plan, the quality of the care provided under the plan, or the size of the plan's network. It is only focused on cost sharing. So in general, enrollees pay less out of pocket with higher AV plans, and premiums are generally higher for these high AV plans. So you can see here that bronze plans, as you may know, tend to have some of the lowest premiums of marketplace plans. They also have only 60% actuarial value. So typically, an enrollee could expect to pay more out of pocket when they need to get healthcare. Whereas by comparison, platinum plans, which aren't available in all areas, but they are still available in some, have a 90% actuarial value. So they're covering a lot of the costs when people are getting healthcare, but they also tend to have the highest premiums. So here's an example of the different metal types and how AV affects cost sharing for these plans. And this example is looking at what these plans cost with no premium tax credit, no financial help. And just wanted to note that that's not going to be the case for the majority of people. Most people are going to qualify, or most marketplace enrollees qualify for the premium tax credit. So we see with the bronze plan, which has a 60% AV, the base premium is $285 a month. The deductible is $9,100, so pretty close to the maximum allowed out-of-pocket limit. And for copays and cost sharing, there is no charge after the deductible, but it also seems that there isn't much coverage before someone reaches the deductible. So this might be a good option for someone with a lot of routine, expensive medical needs who knows they're going to hit their deductible no matter what. But a lot of people aren't going to get anywhere near $9,100 in out-of-pocket spending. So for these people, they're essentially going to have to pay the entirety of their healthcare costs out of pocket. In comparison, silver plans have 70% AV. You can see that the premium is a bit higher than the bronze plan, and the deductible is a bit lower. And when you look at the copays, there are a couple categories where there is coverage, there are copayments as opposed to coinsurance from day one. So they have pre-deductible coverage. For the gold plan example, again, premium slightly higher, deductible significantly lower than the other plans we've looked at. And likewise, cost sharing is lower compared to the silver plan. So for primary care, for the silver plan, there's a $50 per visit copayment. For the gold plan, it is $20 per visit. And then finally, with the platinum plan with 90% AV, again, you've got the highest premium of the four, the lowest deductible. The deductible is $0, and the lowest co-payments and cost sharing as well. Now, as I mentioned earlier, there is financial help available for people at the lower end of the marketplace income scale that lowers the cost of deductibles, out-of-pocket limits, co-pays, and coinsurance. And in fact, about half of all marketplace enrollees are eligible for this assistance. And it's called cost sharing reductions, or CSRs. So cost sharing reductions are a marketplace subsidy that reduces the out-of-pocket costs an enrollee has to pay for medical care. In order to receive CSRs, a person has to have income at or below 250% of the federal poverty level, which is around $45,000 for a household of one, or $94,000 for a household of four. And the lower a person's income is, the more help they receive. People also have to enroll in a silver plan in order to receive CSRs. And unlike the premium tax credit, which the government pays for and which people have to reconcile at tax time, insurers build CSRs directly into their plans. So a lot of people who receive CSRs or who are eligible for CSRs aren't necessarily aware that they're receiving this help. So you can see here that there are 3 levels of cost sharing reduction plans based on income. People earning above 250% FPL aren't eligible for CSRs. People with income between 200 and 250% FPL are eligible for a 73% AV CSR plan, so a little bit better than the standard silver plan, which has 70% actuarial value. People with slightly lower income, so between 150 to 200% FPL, are eligible for an 87% AV CSR plan. So if you remember, that's higher than the AV for a standard gold plan, pretty close to the AV for a platinum plan. And people with income at 150% FPL or below are eligible for a 94% AV CSR plan. So that is even more generous coverage than a platinum plan. In this chart, I've also included the income range for a household of one or a household of four for each of these FPL income levels. And you'll also notice that the maximum allowed OOP limit for individuals or families in 2023 also gets lower as income decreases. So this is kind of an example of how cost sharing reduction plans work or look. 2 things to note here. First, in the yellow highlight, you'll see the plan ID. And the plan ID for all of these examples we're looking at is the same. And that's because this is all the same silver plan. It's just that once the cost sharing reductions are built in, the cost sharing kind of shifts down for the enrollee. You'll also note that in the orange highlight, there's an extra savings icon. And this icon can help you or help the enrollee identify which plans come with these CSR extra savings. So in the no CSR plan, for someone earning above 250% FPL, it's just a standard silver plan. The person would owe $191 monthly in premiums for this plan, so they are still receiving a premium tax credit. And their deductible is $6,500. Their out-of-pocket max is $9,100. If their income, however, is between 200 and 250% FPL, they would get this 73% AV plan variant. So their premium is a bit lower because they're lower on the income scale. And we see that their deductible and out-of-pocket maximum and even their cost sharing, co-payments and co-insurance have decreased as a result. For people with incomes between 150 to 200% FPL, they qualify for this 87% AV CSR plan variant. Their premiums are lower because their income is lower, and because they have this higher AV CSR plan, they have lower deductibles and out-of-pocket maximums. And then finally, for a person with income below 150% FPL, their premium is $0 because they have very low income relative to other marketplace enrollees. And their deductible is just $300. Their out-of-pocket maximum is just $800. So as you can see, CSRs can significantly lower the cost of getting healthcare. But for a variety of reasons, many people who are eligible for CSRs don't enroll in a silver plan, and so they miss out on these savings. So healthcare.gov has a few different features to encourage people who are eligible for CSRs to enroll in a silver plan. The first, as I mentioned, is this orange extra savings icon next to silver plans. The second is this kind of warning that pops up if someone who's eligible for CSRs selects a bronze, gold, or platinum plan. This kind of pop-up box flags that they can save more if they enroll in a silver plan. And then finally, and this is new for the 2024 open enrollment season, CSR eligible people who are enrolled in a bronze plan, but who don't come back to the marketplace to select a new plan during open enrollment will now be automatically re-enrolled into a silver plan if a few important conditions are met. So this will only happen if there is a silver plan available within the same product, with the same provider network, and with a lower or equivalent premium after accounting for the premium tax credit. So that is to say that no one who's automatically re-enrolled into a silver plan from a bronze plan because of this new policy should have a different provider network than they had previously, or should be paying higher in premiums. So let's go through another example similar to what we saw with Anita of how a CSR plan works. So this is Audrey. Like Anita, she had some bad health incident. It has $27,000 in medical expenses, but she has a silver plan and qualifies for CSRs. So you can see her deductible is much lower than, deductible and out-of-pocket limit are lower than Anita's. So similarly, Audrey is responsible for the full amount of healthcare services received before she hits her deductible, which is $300. Once she hits her deductible, she begins to pay co-payments and co-insurance, and the insurer covers the rest. And then once she reaches her annual out-of-pocket limit, she is not responsible for any more medical costs that are in network and covered by the plan. Audrey's plan works a bit differently from Anita's. So for Audrey, she is responsible for 10% of ambulance costs after she reaches her deductible. She gets charged a flat $300 fee for hospital facility fees after she reaches her deductible. After she reaches her deductible, she does not pay anything for hospital physician fees. After she reaches her deductible, she's responsible for a $50 copayment for imaging, so x-rays, etc. And she has day one coverage of medications, and she would have to pay a $5 copayment for each medication she receives. So again, the first item on Audrey's bill is this $1,000 ambulance charge. She pays the first $300, reaches her deductible, and then pays 10% of the remainder. Again, next she receives a charge for a hospital facility fee. Because she's reached her deductible, she is charged $300, and the plan picks up the cost for the rest. Next, she's charged a hospital physician fee, and again, because she's reached her deductible, she is not responsible for anything. Let's say she needs 3 x-rays, so she pays, would pay $150 for that, but after the first 2 x-rays, she's hit her annual out-of-pocket limit. So she pays $100 and her plan picks up the cost of the rest. And then for prescription medications, again, because Audrey has already hit her annual out-of-pocket limit, she is not responsible for the cost of these medications. So her total ends up being $800. Now, like any type of plan, there are still going to be variations between CSR plans, similar to comparing to silver plans or to bronze plans or etc. So we can see here, like as you can tell with the orange icon, these are both plans that have CSRs built in, but there are still some key differences here. The first is the premium. So the premium for Plan A is lower than the premium for Plan B. We can also see that Plan A has a lower deductible than Plan B. The cost sharing pretty much across the board is lower for Plan A. Plan B does cover child dental, which Plan A does not. But Plan A also covers all of the healthcare providers and medications that this person might need, whereas Plan B does not. And you can kind of see the differences in cost sharing reflected in the estimated total yearly cost. So the estimated cost for Plan A is lower than the estimated cost for Plan B here. Special assistance with cost sharing is available to members of federally recognized Native American tribes and Alaska Native Claims Settlement Act corporation shareholders, so ANCSA or AIAN. They can enroll in or change marketplace plans each month without needing to qualify for a special enrollment period. And for AIAN people with incomes between 100 and 300% of the federal poverty level who qualify for the premium tax credit, plans with zero cost sharing are available. So enrollees would pay no deductibles, co-payments, or other cost sharing when using in-network covered essential health benefits. And some out-of-network care is also available with zero cost sharing. For AIAN people with incomes below 100% FPL or above 300% FPL, there is a limited cost sharing plan available. So with these plans, the enrollee would pay no cost sharing charges to receive services from an Indian Health Services provider or from another provider if they're referred from an IHS provider. Next, we'll go over some plan design resources, the most important of which is probably the Summary of Benefits and Coverage, or SBC. So to find the SBC, you would look at the kind of plan display on healthcare.gov and click Summary of Benefits, circled in red there. And you will see a document that includes information that looks like this. You can read through this document and look and see how much the enrollee would be responsible for certain services. So first of all, you might want to look and see if there are services covered before the enrollee meets their deductible. And for this plan, yes, and they note that it's listed as, quote, deductible does not apply or no charge. You might want to look at types of healthcare professional visits or office visits that the person might need. So you can see here for a specialist visit with an in-network provider, the enrollee would be responsible for an $80 copay per office visit, and the deductible does not apply to this. And they're responsible for 10% coinsurance if they go to see a specialist and need other services, like maybe, I don't know, other services that are delivered by the specialist. And you would also want to take a look at any limitations, exceptions, or other important information. Beyond the Basics also offers a resource to help compare plans. So our Marketplace Plan Comparison Worksheet lets you compare up to 4 plans side by side. You can fill it out on your computer and then print or email it to your client. And it is available in 8 languages. Another A resource that can help with plan comparison is easy pricing plans or standardized plans. So marketplace insurers are required to offer plans with standardized cost sharing amounts. This is required for plans that offer a plan, or for plans of each network type and at every metal level for which an insurer has a QHP in a given service area. So for example, if an insurer offers a gold HMO plan in a service area, it must also offer a gold HMO standardized plan or easy pricing plan throughout that area. This rule doesn't apply in state-based marketplaces, Delaware, Louisiana, or Oregon, as many of these states already have implemented their own standardized plan requirements. And on healthcare.gov, they're marked with this green easy pricing tag. And the purpose of these easy pricing plans is that because cost sharing is the same across plans, consumers can focus on other plan features like in-network providers when comparing plans. So to find these easy pricing plans, you would go to the filter option on healthcare.gov. And you can see here underneath each metal type that's offered, there's a checkbox that says with easy pricing. So these are two examples of easy pricing or standardized plans. And you can see here that the deductible, out-of-pocket maximum, and all of the copays and coinsurance are the same across these two plans. So you or your client can focus on other things that are important to the client. So maybe the premium, maybe the healthcare providers that are in network, maybe medications that are covered by the formulary. I'm going to wrap things up by talking about subpar plans. Sometimes these are called limited benefit plans, junk plans, or skimpy plans. They include different types of plans like short-term limited duration plans, association health plans, healthcare sharing ministries, indemnity plans, and Farm Bureau plans. And these subpar plans do not meet standards outlined in the ACA for plans sold to individuals, and they're not certified by the Federal Health Insurance Marketplace or state-based marketplaces. These plans don't have to include the ACA's consumer protections, so they're able to charge higher premiums based on gender or whether a person has a pre-existing condition. They can deny people coverage based on pre-existing conditions. They can impose annual or lifetime coverage limits. They can deny claims for pre-existing conditions. They can exclude essential benefits, and they can also pay out limited amounts for healthcare. These plans, in short, can expose people to high costs, and often they're not that cheap, especially since after the passage of the American Rescue Plan Act and the enhanced premium subsidies, many people can get relatively inexpensive QHP plans. I'm going to dive in a bit on short-term plans since these are maybe one of the most common types of plans you might encounter. So short-term limited duration plans typically exclude coverage for pre-existing conditions and deny claims related to these conditions. Insurers can consider a condition pre-existing even if it wasn't pre-diagnosed or treated, and even if the enrollee wasn't aware of it. Insurers can also conduct post-claims underwriting, and this is when an insurer investigates the health history of an enrollee in order to find a link to a pre-existing condition, which might exempt them from having to pay for services for that condition. And people with pre-existing conditions may be denied a policy outright. Short-term plans are not required to cover essential health benefits and often don't cover prescription drugs, maternity care, mental health benefits, and substance use disorder treatment. They can impose overall limits on plan benefits, lifetime limits, and per service limits. They're not subject to cost-sharing limits like the out-of-pocket maximum. The short-term plan may look like insurance with a premium, deductible, and provider network. However, they don't count as minimum essential coverage, so when the plan ends, it does not trigger a special enrollment period for the enrollee. The Biden administration recently proposed federal regulations that would strengthen consumer protections for some subpar plans and differentiate them from comprehensive insurance. This proposed rule would limit the initial term of short-term plans to 3 months with the option to renew for 1 month. Currently, short-term plans can have an initial term of up to 364 days and renew for up to 3 years. The proposed rule would prohibit plan stacking or selling short-term plans with successive end and start dates. It would prohibit fixed indemnity plans from mimicking benefit designs used by comprehensive health insurance plans. And it would strengthen consumer notices that clarify that short-term plans and fixed indemnity plans are not comprehensive insurance. This rule has not been finalized and is not yet in effect. So how do people find subpar plans or fixed indemnity plans or other plans like this? They're not sold through healthcare.gov. However, the federal marketplace allows the use of direct enrollment or DE and enhanced direct enrollment or EDE websites. Insurers and brokers can use these DE or EDE sites, their own websites, rather than healthcare.gov to let people apply for and enroll in marketplace plans and receive subsidies. And the difference between DE and EDE websites is that DE sites send the consumer back to healthcare.gov for an eligibility determination, and then they get sent back to the DE website for plan selection, whereas enhanced direct enrollment allows the insurer or broker to keep the insurer at their own website for the entire process. Some DE and EDE websites sell short-term and other subpar plans. And while federal rules bar these plans from being displayed next to QHPs, some websites still heavily promote them. And some DE and EDE websites try to sell subpar plans to people eligible for Medicaid instead of helping direct them to the right resources to enroll in Medicaid. Potentially just because they're not set up to assess people for Medicaid eligibility. There are a few things you can do to help as an enrollment navigator, sister, agent, or broker. You can promote open enrollment and healthcare.gov or your state-based marketplace. You can understand and inform people about the risks of short-term plans and other subpar plans. You can promote special enrollment periods for people who face coverage gaps. And you can track and report what's happening on the ground, particularly misleading or fraudulent marketing tactics, inaccurate information provided to consumers, the experiences of people who enroll in these plans, and then you can inform insurance regulators, so typically the state's Department of Insurance, about potential fraud and misinformation, and let individuals know about their right to complain about wrongdoing. So that's it for my presentation. Now I think we'll open it up to questions from you all.
Yes, thank you, Claire, for a great presentation, and we have really good questions to follow up on everything you mentioned. So starting off is, do all enrollees have both a copay and co-insurance, or is it one or the other?
Great question. So for most plans, you would have either a copay or co-insurance for a particular service. But as you can see, let me try to go back to one of my examples. Well, let's do this one. I know the print is tiny, but you can see that for this plan, there is a $20 per visit copay for primary care and a 30% co-insurance after a person reaches their deductible. So plans can have some services with copays and some services with co-insurance.
Awesome. So another question is, do any copays get applied to the deductible?
So I assume that this is a question about pre-deductible coverage, right? So if someone has a $25 copay starting on day one, does that apply to the deductible? The answer, I believe, is yes. That's still an out-of-pocket cost, and so it would still count as progress toward both the deductible and out-of-pocket maximum, so long as the service is received in network.
Great. So another question is, can a person have a marketplace plan and a short-term limited duration plan?
That's an interesting question. I think it would be possible, but I'm not sure if it would be beneficial for the person to be paying for health insurance for two separate plans. I know Jenny is on the call as well. Do you know if this is something that happens?
Sorry, I do not. I am not an expert in the outside the marketplace plans.
Yeah. I think the answer is that yes, it could happen, but it's probably relatively rare, but I can get back to you on that, Julia.
Yes, and the Q&A chat will be saved. So if we can, we will definitely follow up on the questions being asked today. So just continuing on with a couple more questions. What is an example of a health service that is not considered an EHB?
So this can vary by state, and as a reminder, EHB is essential health benefit. So although federal law requires all QHPs to provide coverage of EHBs, states can decide which specific services they consider to be part of an EHB. So, for example, some states consider chiropractic care to be part of the habilitative and rehabilitative care benefit, while others do not. And some other areas where there can be more variation between states include coverage of bariatric surgery, infertility treatment, and speech therapy.
Awesome, great. Another question is, if someone switches plans in the middle of the year, does their deductible and progress toward their out-of-pocket limit reset?
Typically, yes, the deductible and out-of-pocket limit will reset if a person switches plans mid-year, even if the plans are both offered by the same insurer. So this is definitely something to keep in mind. Certain people with incomes below 150% of the federal poverty level, or American Indians and Alaska Natives are able to switch plans mid-year. However, if they've already made progress toward meeting their deductible or out of pocket, they might not want to use that option because their deductible and out of pocket would reset in most cases.
Great. So another question is, what happens if a hospital is in network, but a doctor or other clinician isn't?
So this is actually very pertinent. So under the No Surprises Act, which is a federal law that took effect recently in 2022, an insured person can't be balanced billed for either emergency services that are received out of network, or if they get non-emergency services from an in-network hospital, emergency department, or outpatient surgical center. So the facility is in network, but they get a bill from a provider who's not in network with their insurance plan. So in both of those cases, emergency situation with an out-of-network provider or non-emergency situation in an in-network facility with an out-of-network provider, people can't be balance billed. A person can waive their right to these protections if they sign something called a notice and consent form, which does allow their provider to balance bill them. And if people are getting billed for or balance billed for these services when they shouldn't, they can report that to CMS by visiting cms.gov/no surprises.
Great. And one last question for the Q&A.
Mm-hmm.
I wasn't aware that people who enrolled in short-term plans or subpar plans were eligible for subsidies. Is that new?
No, I apologize if there was a misunderstanding. So short-term plans and subpar plans are not eligible for the premium tax credit or cost sharing reductions.
Okay. Awesome. Thanks for clearing that up. I think we can just go to our closing slide. Thank you. So as you can see, these are all the resources that were discussed in today's slide, and they will be available in the slide deck and on our website. As a reminder, we will be distributing the resources from today's session via email, and we will post everything to the Beyond the Basics website at healthreformbeyondthebasics.org. Next slide. And here are the contacts that you can reach Claire at, and then of course, for any general questions at beyondthebasics@cbpp.org. And last slide. So we've got 2 webinars coming up next week: Plan Selection Strategies next Tuesday, October 10th at 2 p.m., and Renewals and Redetermination Process on Healthcare.gov on Thursday, October 12th, both at 2 p.m. Eastern Time. You can register for this and other upcoming webinars on the Beyond the Basics website. And with that, we will bring this webinar to a close. Thank you again for joining us today.